Team 5 is pleased to present narcotics addiction among healthcare employees. The drug industry has changed significantly in the past decade. Starting in 1991, medical professionals wrote approximately 76 million opioid prescriptions. This may seem like a lot, but this sum has grown significantly in recent years. Also, the epidemic for drug abuse has grown. Pharmaceutical companies have been thriving. Purdue launched OxyContin in 1996, which resulted in $45 million in sales. Since Purdue's launch of OxyContin, the brand produced an aggressive marketing campaign to push the product. By the year 2000, the sales for OxyContin grew to $1 billion. And following that, heroin deaths doubled from 2012 to 2015 from 380,000 to 670,000. In addition, the number of opioid prescriptions that were written by medical professionals by 2013 had increased to 207 million, over 3 times the original amount of prescriptions in 1991. Now, we live in a world where an estimated 26 to 36 million people are believed to be abusing opioids worldwide. Moreover, the White House just recently requested $1 billion in medication-assisted treatment for its 2017 fiscal budget. Doctors, pharmaceutical companies, and the FDA will all admit there is a problem with drug abuse. Though the FDA has continued to state that they're reassessing the risk-benefit paradigm for opioids, solutions have yet to be provided. Instead, pharmaceutical companies are capitalizing off the industry by raising prices for overdose reversal prescriptions, such as naloxone, also known as Narcan. In addition, there was a period when doctors were penalized for not writing enough opioid prescriptions. Other alternatives exist, but have yet to be accepted within the medical industry. Alternative, non-addictive medication are typically more costly and do not work as effectively, thus making opioids the more convenient option for the patient and doctor. Dr. Gail D'Onofrio from Yale School of Medicine's Pain Medicine Division sees this epidemic as a priority by stating, when patients complain of pain, we need to be better at alternative treatment and not always just quickly writing prescriptions for opioids. The problem is that the alternative methods take longer, but we can't just keep prescribing these drugs the way we've been doing. Finally, drug addicts commonly live under a stigma that judges drug abuse instead of providing awareness and tools for proper treatment. Instead, the pharmaceutical companies and government profit off the epidemic by creating more drugs to help individuals cope, such as Suboxone, Methadone, and Vivitrol, instead of promoting abstinence. We've provided a link below for you to cut and paste and watch this video on your own. It's only approximately 5 minutes long, but it's a very interesting and emotional story told by Governor Chris Christie of New Jersey, who talks about a friend of his, a fellow attorney, who became addicted to opioids after a back injury. And Governor Christie takes us through the pain and suffering of not only his friend, but his friend's family and the aftermath that the opioid addiction caused. Before we go too far, we'd like to first explain why drug abuse can occur. The National Institute on Drug Abuse argues that drugs change the way the brain works. Physiologically, drugs have various ways of creating the feeling of elation, one of which is commonly done by increasing the concentration of dopamine at the synaptic cleft of the nervous system synapses through a process of exocytosis. These small sacs, also known as vesicles, are filled with dopamine which bind to receptors at the postsynaptic endings. This ultimately creates electrical impulses that travel to the brain. They essentially flood the brain's reward circuits with stimuli, ultimately creating a feeling of elation and high like nothing natural. As a consequence, the body starts to either shut down dopamine production or limit its response to it. This is the start to tolerance. And tolerance leads to the scenario where more and more drug is needed to create the same level of elation as once achieved with a much smaller dosage. A vicious cycle is formed. The evolution of drugs has changed drastically over the years. In recent years, the common forms of narcotics include morphine, heroin, opium, Percocet, codeine, and Vicodin. There are several signs to look for in someone who may be abusing drugs. They include becoming less reliable, more violent, and not as involved with family and friends, or a general move toward isolation. Physical changes such as weight loss, sores or lesions, track marks or clothing that covers track marks. For instance, a long sleeve shirt on a hot day. Some may see declined dental health with methamphetamine users, often referred to as meth mouth. Nosebleeds and constant sniffling or congestion when not sick are sometimes seen with snorting cocaine. Personal hygiene as well as general appearance will decline as well. And bloodshot, glassy eyes or excessive pupillary constriction is seen with opiates. Now we'll take a look at how this affects the healthcare industry. According to Critical Care Medicine Journal, healthcare professionals account for one of the largest rates of addiction in the workforce. One primary reason why is because medical professionals have such high-stress jobs. Medical professionals struggle with physical and mental health issues, despair, and unsupportive professional environments. An article by USA Today titled "Doctors, Medical Staff on Drugs Put Patients at Risk" provides an example of a doctor who started using narcotics to deal with the stress of his job during his residency, and by the time this employer discovered this problem, the doctor was consuming, on average, 100 pills a day. There are several reasons why medical professionals can easily get away with such efforts. Healthcare professionals literally have direct access to these drugs, and surveillance and drug tracking systems can't be relied upon. In addition, drug screenings are not mandated in any state, leaving it completely up to the hospital to decide how they want to screen for their potential and current employees, which is a very costly investment. Typically, hospitals will screen individuals initially, but do not continue drug testing when hired. And finally, once an individual is caught, many states lack rules that require medical facilities to report these incidents. Instead, they only continue the behavior somewhere else. Without a formal program in place, an individual has the opportunity to game the system by submitting fake urine tests. In addition, without properly treated, he or she can return to the same hectic work environment, ultimately leading them back to drug addiction. In the following section, we're going to explain how drug addiction affects the workplace. According to the National Council on Alcoholism and Drug Dependence, the impact of alcoholism and drug dependence in the workplace affects four major issues, and they include premature death and fatal accidents, injuries and high incidence of accidents, absenteeism, and loss of production. Additionally, it also affects decision-making, efficiency, morale, interpersonal relationships, and it causes distraction and preoccupation with obtaining and using substances at work, needless risk-taking and illegal sales of drugs to coworkers, and other illicit activities as well. Contrary to conventional wisdom, most Americans with substance abuse disorders continue to be functional and hold down a job. Research shows that 70% of Americans who use illegal drugs are in fact employed. At a rate similar to or exceeding the general population, approximately 12% of physicians develop a substance use disorder during their careers. And reporting an impaired colleague has its challenges. For a colleague who suspects addiction in a peer, the challenges of confidently identifying and intervening include everything from a concern of what right do I have to tell them how to live their life, to fear of retaliatory litigation. Additionally, the medical licensing boards in many states have established sanctions if a physician becomes aware of an addictive disease in a colleague and fails to intervene. The initial confrontation with a suspected addict requires preparation and logistical support. The person intervening should never approach the suspected addict one-on-one and ask if he or she is addicted or suggest that he or she stop using or divert drugs. This approach is not suggested as denial is the hallmark of addiction and potentially dangerous because the threat to the physician's status, autonomy, security, and financial ability may drive him or her to act of desperation such as suicide. According to the Mayo Clinic proceedings, in the setting of acute intoxication in a physician who provides patient care or who might be expected to provide care, immediate removal from the setting is essential. An intervention will include accompanying the suspected addicted physician to an established healthcare environment, such as the employee health clinic or emergency department, where immediate drug testing can be taken. If testing confirms acute intoxication, this portion of the intervention, such as the documentation of substance abuse, is now complete. Care of the physician who abuses drugs now involves taking him or her to a facility that can evaluate for addiction. Adherence to pre-existing institutional policies is important. In a less urgent situation in which addiction is suspected in the absence of workplace intoxication, it is critical that before intervention, there's a plan for a chain of custody transfer of the suspected addict to the area where he or she will be evaluated, whether that's at an employee health clinic, a state health program, or directly to a chemical dependent expert. Most PHPs will provide invaluable assistance with either conducting an effective intervention or providing a recommendation for referral to a third party specializing in interventions. Many physicians can successfully return to practice with a solid addiction recovery and monitoring program in place. Any physician returning to practice should engage in his or her state's physician health program, and in general, such participation is mandatory. These programs are usually led by physician advocates, and they provide resources for individual and group therapy, psychiatric care, mutual health meetings, body fluid monitoring for drugs of abuse, and workplace education and monitoring. Usually, physician health programs require contracts with the physician that document expected activities and require compliance with them to ensure abstinence and successful return to practice. Failure to comply with the program required by the physician's health program will result in reporting to the state's medical licensing board, at which point there will typically be disciplinary action with the possibility of public disclosure, sanctions up to and including license suspension, or in extreme cases, revocation. The physician's health program will generally manage the logistics of obtaining and monitoring required drug screens, both random and for cause. Returning to a group practice setting with the provision of on-site supervision by peers is considered optimal, but typically is not mandatory. Studies show that physicians who participate in PHPs do well overall. A study of 904 patients in a PHP found an overall return to work rate of 79% after 5 years. 15% stopped practicing and 11% lost their license. This study showed that most physicians with impairment, when recognized and treated, don't lose their jobs, and are able to be rehabilitated and continue to contribute as physicians. Physicians need to want treatment and be compliant with treatment and subsequent follow-up, which would likely include random drug tests and alcohol tests. Another study of emergency physicians found that physicians had an 84% success rate in completion and return to clinical practice after 5 years. Of the 3 outcome variables, rates of relapse, successful completion of monitoring, and return of clinical practice, these physicians had a high rate of success on all variables. This data supports the conclusion that emergency medicine physicians do well following treatment of substance abuse disorders with monitoring in PHPs and generally return to the practice of emergency medicine. Let's take a look at some legal implications involved with drug abuse and drug diversion in the workplace. State laws vary on drug testing. Some states don't allow drug and alcohol testing unless the employer has a written drug and alcohol testing policy in place and that it meets certain legal requirements. Some state laws restrict random testing and limit grounds for testing based on reasonable suspicion. State medical licensing boards typically require physicians to self-report and to report on other physicians who are unable to practice medicine safely because of drug or alcohol use. Most states have a bypass mechanism that allows foregoing of a report to the licensing board and instead allows a report to the PHP in order to satisfy this requirement. Federal laws such as the Americans with Disabilities Act and state civil rights laws generally protect physicians actively engaged in chemical dependency treatment programs as well as recovering addicts. And these laws generally required what's called reasonable accommodation for the recovering alcoholic and drug addict. As an example, a modified work schedule. Furthermore, federal and state laws mandate job protection, typically up to 12 weeks during a medical leave for addiction treatment. When a physician returns to work after treatment, employers and hospitals can impose restrictions on employment, as described in the previous section. Clinics and hospitals should specify to the returning physician the consequences of a relapse or failure to comply with any of the return to work conditions. And finally, we'll discuss how healthcare workers can seek treatment once they're seeking recovery. According to the Institute for Behavior and Health, addicted physicians receive an intensity, duration, and quality of care that is rarely available in most standard addiction treatment. Their programs include a prolonged residential and outpatient treatment, at least 5 years of extended support and monitoring, including a contract with their PHP and support from family, colleagues, and employers. Successful treatment programs for physicians are often run by healthcare workers who specialize in physician care. It's crucial for physicians to feel comfortable in the program. Therefore, it should be located well outside of their medical community. The Alcoholics Anonymous model, established in 1938 by Alcoholics Anonymous founder Bill Wilson, Bill W. noticed the positive effects alcoholics experienced after sharing their stories with each other. And still today, the Alcoholics Anonymous meeting and the AA program remains a crucial tool for long-term sobriety. It's widely reported that relapse rates among physicians is lower than the rest of the recovering population. Physician health benefit programs include constant support, counseling, and advocacy for self-help groups such as AA and NA, Narcotics Anonymous. PHPs give physicians rigorous support for up to 5 years. A study recently conducted among roughly 1,000 doctors showed that 78% had a completely negative drug test result throughout the 5-year period, and 71% remained in the medical field. So here's what we've learned. That addiction is prevalent. It continues to grow in the United States. It's very easy to become addicted, and it's very difficult to seek help. That healthcare professionals need our help. Their high-stress jobs, their ease of access to the medications are making it one of the largest industries suffering from drug addiction in the workplace. And that recovery works. Results have proven that employees engaging in a proper physician's health program find long-term sobriety. And that suggests it can be beneficial to the general population as well. This concludes our presentation. Thank you for listening. Hope you enjoyed the class as much as we did.